Welcome to Final BDS MADC. Paget's disease is one of the important 7-marker questions from the subject of oral medicine. It is also known as osteitis deformans. It is a chronic progressive disease of bone. It is a common skeletal disorder of middle-aged and elderly patients involving multiple bones called polyostotic or rarely single bone called monostotic. It is characterized by abnormal and excessive remodeling of bone in which there is initially increased osteoclastic activity. This is followed by accelerated but abnormal bone formation and increased vascularity of the bone. Because of these, bones become enlarged, weakened, and deformed with associated complications. Etiology. Although many theories have been articulated, the etiology of Paget disease is still unknown. Evidence exists of a genetic link, as many patients with Paget disease gave a family history of the disease, and based on the phenotype, a possible autosomal dominant inheritance has been suggested. Genome-wide searches and linkage analysis have resulted in several Paget susceptibility genes (PDB1 to PDB7) spanning over the chromosomes 2, 5, 6, 10, and 18. A viral etiology has been considered after the identification of nuclear inclusion bodies in osteoclasts that resembled viral nucleocapsids of paramyxovirus, especially canine distemper virus and measles virus. Other suggested etiologies include inflammation and autoimmune connective tissue and vascular disorders. Next are the clinical features. It is seen most frequently in Britain and less frequently in North America and Western Europe. It is seen predominantly in patients over 50 years of age. Men and women are equally affected. It is prone to occur in the axial skeleton, especially the skull, femur, spine, tibia, and pelvis. It is usually polyostotic. First complaint is that patient needs to buy a hat of larger size because of skull enlargement and frontal bossing. Bone pain is a consistent symptom and most often directed towards weight-bearing areas, and the pain may worsen at night. Long bones, that is femur and tibia, may be bowed because of the lack of rigidity to support the weight and curvature of spine, especially lumbar and sacral regions. Then the skin over the affected bone may feel warm to touch because of increased vascularity. Softened bone at the base of the skull may lead to platyphagia, the descent of the cranium into the cervical spine. Then simian appearance can be seen like an ape or monkey. Then waddling gait is a feature, that is broadening and flattening of the chest and spinal curvature. So the patient assumes waddling gait. Secondary complications include headache, paresthesia, cranial nerve deficits, hearing loss, optic nerve atrophy and blindness, and neuralgias. At the oral manifestations, both the jawbones are commonly involved with a slightly higher incidence in the maxilla. There is progressive enlargement of the jaws, widening of the alveolar ridge, and flattening of the palate. The teeth may migrate, resulting in excessive spacing between teeth. Denture-wearing edentulous patients often complain about tightening of the dentures because of the expanding alveolar ridge. The dentures may be remade periodically to accommodate this increase in size of the jaws. As the disease progresses, the mouth may remain open, exposing the teeth because the lips are too small to cover the enlarged jaw. Next are the radiographic features. Generally, the appearance of the internal structure depends on the developmental stage of the disease. The three radiographic stages are an early radiolucent resorptive stage due to decreased trabeculae, a granular or ground glass appearing second stage, a denser, more radiopaque appositional late stage when the trabeculae may be organized into rounded radiopaque mass showing a cotton wool type appearance. When the mandible is affected, the bone scan may demonstrate marked uptake throughout the entire mandible from condyle to condyle, a feature that has been termed Blackbeard or Lincoln sign. Particularly in the skull, large circumscribed areas of radiolucency may be present, which is called osteoporosis circumscripta. Generalized absence of the lamina dura may become evident and may be altered into the abnormal bone pattern. Generalized hypercementosis develops on a few or most of the teeth in the involved jaw. Tam-o'-shanter appearance, that is, Paget's involvement of the skull, leads to widening of the diploic space, enlarged frontal bone, and an overall enlargement of the cranium, combined with platybasia, leads to the appearance of the skull falling over the facial bones, similarly to the Scottish tam-o'-shanter hat falling over the head. This is how it looks. It is the appearance of the skull falling over the facial bones, similar to Scottish tam-o'-shanter hat falling over the head. This appearance is due to widening of the diploic space, enlarged frontal bone, and an overall enlargement of the cranium. Next are the laboratory findings. Serum alkaline phosphatase levels are usually elevated. Alkaline phosphatase levels rise to as high as 250 Bodansky units, particularly in osteoblastic phase of the disease. Serum acid phosphatase level is usually within the normal limits. The urinary hydroxyproline level is also elevated because of the increased osteoclastic activity and bone resorption. Recently, urinary excretion of bone-specific pyridinium collagen crosslinks, N-terminal telopeptide, and alpha-collagen C-telopeptide has been found to be a sensitive and specific marker of bone resorption. An abnormally high alpha-CTX beta-CTX ratio is seen in the active phase of Paget's disease, and the values return to normal once the disease is treated with bisphosphonates. Next is the differential diagnosis. For early stage, it is giant cell lesions of hyperparathyroidism, osteoporosis, osteomalacia, multiple myeloma. For second stage, it is osteogenic sarcoma, cementifying and ossifying fibroma, fibrous dysplasia, osteoblastic metastatic carcinoma, ossifying subperiosteal hematoma, ossifying post-surgical defect, chronic osteomyelitis, chondroma and chondrosarcoma. For advanced stage, it is florid osseous dysplasia, osteosclerosis, tori, and osteoma. Last is the treatment. Pharmacological therapy includes bisphosphonates, that is alendronate, often used as first-line therapy. Dose is 40 mg once daily or 70 mg once weekly. Then risedronate, another option with dosing typically at 30 mg once daily or 35 mg once weekly. Zoledronic acid, it is given intravenously at a dose of 5 mg over at least 15 minutes, and it is usually administered annually. Then calcitonin is used for pain relief in patients who cannot tolerate bisphosphonates or when bisphosphonates are contraindicated. Salmon calcitonin is administered as a nasal spray or injection, subcutaneously or intramuscularly. Then NSAIDs or opioids may be prescribed for pain management. Surgical intervention includes orthopedic surgery, that is corrective surgery, for severe deformities that impair function or quality of life, fracture management, neurosurgical intervention. Supportive measures include physical therapy, nutritional counseling, monitoring and follow-up. Serum alkaline phosphatase levels should be regularly monitored. Radiographic evaluation to evaluate disease progression and treatment efficacy. Considerations for dental treatment. Assess bone health and risk of complications before dental procedures, and monitor healing and consider potential delays in bone healing due to Paget's disease, that is after extractions. That's it. Thank you for watching. If you appreciate this video, do hit the like button, share it with your friends, and please subscribe to my YouTube channel and hit the bell icon for more regular updates.